But if I had to choose between the two, I would choose an MRI above a CT scan, because a lot of things you can pick up on X-ray. The MRI will show you the disc, which can cause problems in some patients. Now the controversy here is, should MRI be done before or after the reduction of the dislocation? People who believe in doing the MRI before reduction say that if there is a disrupted disc, when you reduce the dislocation, it could displace posteriorly during the reduction, which has happened in about 1% or 0.1% of patients, and therefore you should be careful. Anatomy of the injury can be clearly visualized, so when you are doing the reduction, you can definitely plan the surgery also. And because during reduction you are going to use close reduction, you are using cervical tongs which are metallic, then you might find it very difficult to get into a MRI machine. So therefore people often advise MRI before reduction. Those who advise MRI after reduction say that it is not steroids which help, it is not your surgery where you stabilize the spine which is help. The single thing which is most important in helping the spinal cord is a realignment of the spine, reducing the dislocation so that the blood flow etc. improves and the secondary injury to the spinal cord is minimized. So they say the faster you can realign, the better it is. Why waste time for MRI and CT? They say that even in patients who are awake and alert, if you are doing a close reduction which is monitored by you, the chances of undetected neurologic worsening are very, very low. And in fact, they say that the status of the disc after reduction is important, because if it has slipped backwards during reduction, you have to plan an anterior surgery rather than a posterior surgery. So both people have good arguments. How do I do it? I follow a middle path. If patient is without a deficit or a partial deficit, I don't want to take a risk, I will get an MRI done before doing a reduction. All unconscious patients, you must always get a reduction, a MRI. And if the injury is more than 8 hours old, it really doesn't make that much of a difference. You might as well do an MRI before reduction. There are various methods of reduction. Gradual traction, which I think is largely given up. Rapid traction or manipulation with sedation are the methods to do. What does rapid reduction means? Rapid realignment of the spine. I do it in an ICU setting with an X-ray machine. The patient is awake and alert. The doctor, that is me, and the X-ray technician both stay for the entire duration of the procedure. We start with 10 pounds of weight and add 10 pounds every 10 minutes. As soon as we put it in, we check the neurology and get an X-ray done. By the time he comes back with the X-ray, we are ready to add the weight if it is necessary. Typically, we found that it takes between 10 and 180 minutes, that's 3 hours to realign, average of 75 minutes. When do we stop the reduction procedure? Either if the reduction is achieved, or if at any point you find a neurological deterioration, or if the distraction is more than 1 centimeter, or if the facets are locked and you deem the reduction is unlikely. What are the advantages of this procedure? This is a faster procedure than the gradual traction which was followed, so you are quickly realigning the case. 90% of the times it is effective. Some people say even this is time consuming, and they would advise a manipulation of the spine under sedation or GA to reduce the dislocation. I find that extremely dangerous, and I find I can become nervous doing that kind of thing, and therefore I would prefer to do a rapid reduction, if not go for an open reduction with surgery. You've achieved a reduction, or you may not have achieved. Time for some definitive treatment. If you have achieved a close reduction, definitive treatment can be done electively. What do you mean? It means that suppose patient has come at 12 in the night, you must realign the spine and reduce the dislocation. But doesn't mean you go in and operate at that point at 12 in the night. You can do it at 8 in the morning as an elective procedure. But certainly I do not believe in waiting for days like it has been recommended in the olden days, after 5 days and after 4 days. to reduce the chance of cord edema, etc. Because what happens is these people chest deteriorates dramatically, and then 4 or 5 days later when you take them up, they go post-operatively on a ventilator and often don't come out. So I prefer to operate on them as early as possible. But when would I do a surgery at 12 in the night? If it's an irreducible dislocation, if there is a large disc herniation already existing along with the dislocation, if during close reduction neurological deterioration has occurred. Of course, some institutions do it as a routine because they believe that open reduction is the fastest method of realigning the spine. So I know people in Brazil who would, through their trauma services, they would come to know patient is coming, they get an X-ray, it's a bifacet dislocation, no need for an MRI. They would directly go anteriorly because they are dealing with the disc, do the discectomy, so disc is out. From the anterior approach, they would reduce the dislocation and stabilize the spine. They say within 2 hours of the patient coming to the hospital, the whole thing is over, which is faster or much faster than what we could achieve. But it also indicates that you should have a center which should be able to deal with this as fast as they do. The surgical approaches could be anterior, posterior or combined. If you look at the randomized controlled trials comparing anterior versus posterior fixation, there has been no difference in fusion rates, kyphosis, neurologic recovery. So both procedures seem to work adequately well, except for a few times when you have to be very careful. My preferred approach is posterior. Why? Because it is easy and predictability of reduction is better. With anterior surgery, sometimes in spite of all your efforts, you may not be able to reduce the dislocation. Then you have to switch to posterior. Whereas posteriorly, I am almost always sure that in a fresh injury, I can get a dislocation, a reduction. But you must get an MRI because during posterior surgery, you don't know when you are reducing that the disc may slip backwards. So before doing a posterior surgery for reduction, if the reduction has not come, always do an MRI. Posterior fixation, because it restores the tension band, is much stronger than the anterior fixation. And fixation can be easily extended upwards or downwards if necessary. There are various different techniques. We used to use these wiring techniques in the past, but I think a majority of the time now I use either lateral mass fixation or pedicle screw fixation for this approach. Here is one such example, a 41-year-old male with quadriplegia, bifacet dislocation, reduced. What I did was opened it up, partially reduced it, put a wire around the spinous process and tightened it. As I tightened, the whole thing came back into position, and then to neutralize this fixation, this was like an interfrag. The wire is like an interfrag, and to neutralize the interfrag with a plate, I have put these lateral mass plates. Another patient, 24-year-old, you can see a lower cervical bifacetal dislocation fixed posteriorly in a similar manner. What are the disadvantages of posterior surgery? The biggest problem is that you have to turn the patient prone. When you turn the patient prone, if you are not careful and you don't have a good team with it, then you can actually lose the reduction you have achieved and there may be worsening of neurology. When we do it at our center, I get at least 7 or 8 people in the OT to turn the patient around. I manage the head and the neck, and the rest of the people manage the rest of the stuff. Sometimes if there is an associated fracture, facetal fracture like there is in this patient, you may have to extend the fusion an extra level, which if you do anteriorly you may not require. More muscle dissection, more blood loss and axial neck pain. When do I do an anterior approach? If there is a large anterior disc which needs to be taken out, you go anteriorly. If there is a significant compression fracture along with the bifacial dislocation, you might want to do a corpectomy, then you do a anterior approach. Or if you have got a successful closed reduction, you don't want to go posteriorly, do it anteriorly. The advantages of anterior approach: safe position. You are doing it in supine position, no extra effort required. It goes through intermuscular planes, so it's a limited muscle dissection, limited blood loss and very little neck pain. You can achieve everything through a single approach, a discectomy, a reduction, a stabilization, and as I said, it can be performed even without an MRI. This is how you would do an anterior open reduction. Here is one of our patients with a large disc prolapse where we did a corpectomy, reduced this, and then put in a plate with a cage from the front. What are the advantages of an anterior? Disadvantages? The anterior reduction is a much more demanding operation, and sometimes you may not be able to get a reduction, in which case you will still have to flip the patient and do a posterior approach. The other thing is the anterior plate. It's like, you do tibial condyle fractures. Your medial plate is a buttress plate. It just shores up that thing. It has no power against shear and bending forces. In the same way, the anterior surface of the spine is the compression surface. A plate applied on the compression surface is a buttress plate. It just holds a graft in place, but it cannot prevent the shear forces from acting, and sometimes this can displace, especially in patients who have associated facet fractures, or if you have not reduced it adequately. You must make sure that if you are doing an anterior plating, this gap should not be there at the back. You must put it in adequate extension and close the gap at the back, and then contour this plate. This plate cannot be flat like this. It has to be rounded so that it holds the gap, and then please put the patient on a proper immobilization at least for 6 to 8 weeks.
Gautam,
Done. Beware of vertebral artery injuries. 20% of flexion injuries will be associated with vertebral artery injuries. This is just a small thing which I made of how you would treat. But if I was to summarize this lecture, I would say that a bifacetal dislocation is a devastating injury, high incidence of neurologic deficit. Don't think about steroids and all. Those are all secondary things. Your primary goal should be a rapid realignment of the spine. Anterior surgery, posterior, what should I do? Both procedures are very good. It depends on what you are comfortable with. Thank you.
I thank all the speakers and the participants, and I apologize for the 12-minute delay like my next co-chairman prompted. I would like to hand over the next session to the people already present. Thank you so much.
Well, we're going to kick off rapidly with the next session, which is the miscellaneous symposium session. And the first talk is on elbow arthroscopy, a modern perspective on indications. Dr. Anandarya.
Good morning, Mr. Chairman and the friends. I am Anand Arya. I am a consultant orthopedic and elbow surgeon in King's College Hospital, London. It is one of the oldest teaching hospitals of London, a level 1 trauma center, and one of only 5 academic health science centers in the UK in collaboration with Guy's, St. Thomas's and Moseley Hospital. It is also the biggest center for liver transplant in Europe. The elbow arthroscopy is very technically demanding because of the limited space, as well as the presence of the very important neurovascular structures in close proximity to the portals and to the site of surgery. It poses greater challenges and neurological risks than the knee, shoulder or wrist arthroscopies. It has a long learning curve and requires extensive experience, but unfortunately due to limited caseload, it's difficult to accumulate that experience. These are some of the common indications for the elbow scope. I think the first two probably are the most common indications. Anyone who does the elbow scope normally would use the elbow scope for these two indications. The rest 4 indications are for the experienced arthroscopist, when the people can do elbow arthroscopy for treatment of all these conditions. And the last 2 are gradually evolving indications, and they are not well established, but people are trying to use the elbow scope in treating these conditions. If you want to do elbow scope, you have to be really careful and need to know the anatomy in detail. The bony landmarks, they should be very well visualized when clearly palpated. The location of the ulnar nerve should be found out. It is very, very important. Sometimes the normally ulnar nerve may be quite mobile, and at other times it may have been moved due to surgery. So it's very important to find out where exactly the ulnar nerve is. The soft spot is a triangular area between the lateral epicondyle, the olecranon, and the radial head, and it's the safest place to enter to the elbow joint for certain things. Sean Driscoll, who is the world's one of the greatest elbow arthroscopists from Mayo Clinic, he never tires in describing these 4 steps in the elbow arthroscopies. Firstly, enter the joint. It's not always easy to make sure that you are in the joint. Sometimes when the joint is full of fibrous tissue or proliferative synovium, you might be in the joint, but you are not certain. So you need to make sure that you are in the joint, and then you create this space by debriding all the extra tissue. And once you start seeing the articular surfaces, and then you do your bony work first, and any soft tissue work should be done later, because doing the soft tissue work would actually create a lot of edema and extravasation of tissue. Initially, when the elbow arthroscopy started, supine position was used, but now almost everyone, except in small proportion of people, use the prone or the lateral position for the elbow scope. I use the lateral position, and if you want to keep your anesthetist happy, then use the lateral position, because prone position can be difficult to maintain the airway as well as to convert the regional to general anesthesia. Use the tourniquet if at all possible. Leave enough space between the tourniquet margin and the elbow, and seal the tourniquet margins with some tape so that fluid does not go under the tourniquet. It is almost mandatory to mark the portal sides, and even the expert elbow arthroscopists, they do it, and they do it themselves. The arm is always prepared, wrapped, and usually bandaged up to the elbow, and it helps in reducing the extravasation of the fluid into the forearm. This is nothing special, just the general setup there. Lateral position, surgeon standing on the facing the elbow, and the assistant on one side, and the nurse and the instruments onto the other side is there. As usual, all the video monitor and the recording light sources, they are on the other side of the patient. I use the standard 4mm 30-degree scope. Some people do use the small 2.7 wrist scope. Cannulas can be used if you wanted to switch the portals very frequently. I normally use the cannula only in a very big patient. Usual handheld instruments plus motorized instruments should be used. I use the radio frequency probe quite often for debriding and cutting the tissues. Initially I used to use gravity inflow, but then I normally use the pump now, but keep the pressure under 35 millimeters. Proximal anterior medial portal is the important primary viewing portal there. It's about 2 centimeter anterior and proximal to the medial epicondyle, but important thing is that to make sure ulnar nerve is posterior to it. Initially joint is insufflated, a free flow of the fluid, make sure that it's in the joint, small skin is incised, and it is stretched with a hemostat. Cannula and the scope is inserted after that, and as I mentioned, I use the fluid pump. Proximal medial portal gives a very good view of the anterior joint, the radiocapitular joint, the coronoid, the trochlea, and the anterior capsule. All the tissues can be very clearly seen by it. The anterior lateral portal I use as a working portal. It's almost in the line of the joint, and it's about 2 centimeters anterior to the lateral joint. It can be varied slightly proximal or distal, but I normally prefer it to in that line of the joint. And I normally make this portal under vision, put a needle first, have a look at the needle, then make a small incision there, and after that spread the incision and then put a trocar and cannula there. Posterior portals are relatively safe, and they are posterior central portal and posterior lateral portals. As long as you are not going towards the medial side, you can make 1 or more portals in this line as well as 1 or more portals in this line. I normally use the posterior lateral portal as the viewing portal and posterior central portal as the working portal, but you can always switch it around. Some of the pathological conditions you can treat by the elbow arthroscopy. Tennis elbow is a difficult condition to treat, but if you happen to treat it surgically, it is better to do it arthroscopically, and especially if you can see a lesion which is called a Nurschel's lesion into the elbow. The important thing is that make the lateral portal after viewing the lesion. If you can't view the lesion, then best thing is that to pass a needle to localize the suspected lesion from outside, and I use the radio frequency probe to debride the tissues, debride the capsule, and excise the origin of the ECRB. Removal of loose bodies, probably one of the most satisfying operation of the elbow arthroscopy, and especially when you go outside the theater and hand over the patient or their relatives a bag full of loose bodies and you impress them. And the loose bodies can be idiopathic, post-traumatic, in osteoarthritic, or something like a synovial chondromatosis. So any region of loose bodies, you can always these are some of the tips for removal of loose bodies. Sometimes the loose bodies get lost inside when you're bringing them out to the soft tissues. So you should make the large portals, and you should try to use the large grabbers. And sometimes the loose bodies remains attached with a small amount of soft tissues to the joint. So try to push them, push them away, or rotate them around, and then you can free them completely, and then it's easy to take them out. And if they got lost, try to look for the coronoid or the olecranon fossa. And if you want to be really expert in removing loose bodies, start fishing. Synovial plica is a relatively new diagnosis as into the knee joint, and it has only come after the arthroscopy. It can cause lateral elbow pain, and it can be excised arthroscopically, and normally you would find some osteochondritic chondromalacial changes underneath. Olecranon bursa can be excised arthroscopically. It is a good procedure because olecranon bursa can give rise to a lot of post-operative complications. So if you want to excise it arthroscopically, it can be done. Arthroscopic synovectomy, as I just mentioned, it's a good procedure, and you can do almost the total synovectomy anteriorly and posteriorly. The radial head resection is a new procedure. Some people started doing it. I haven't done any one so far, but I'm sure I would do it soon. The post-traumatic stiff elbow is one of the common conditions which probably in India a lot of people come aware, and the treatment is difficult, results are unpredictable, and I think in the arthroscopic elbow surgery is probably very good for the release of the stiff elbow, and you can remove all the osteophytes, all the tight capsules, and initially you would see that a lot of the joint is full of all fibrous tissue, and gradually you would excise the tissue, the muscle is exposed, capsule is excised, and then you would see that normally you can release these elbows quite clearly. The elbow arthroscopy has got its own share of complications, and nothing much to compartment syndrome can be avoided if you haven't put the fluid at a big pressure there. Neurovascular injuries are common, but you are careful making your portals, then you can avoid it. Elbow arthroscopy is a developing thing, and the arthroscopic stabilization of elbow holds great promise, and people are working on it. Endoscopic ulnar nerve decompression, probably not very good. Same thing, other indications are coming up, and I'm sure that next few years' time, more and more people would do arthroscopy for more and more indications. Thank you very much.
Thanks, Anand. You delivered a very difficult topic in a concise way. Any questions you can ask? If none, we'll proceed to the next topic. Amit is here? Amit Tolat? Ravinder Dimri? Thank you, Ravinder. Dr. Dimri will talk about the sliding hip screw versus nails. That controversy is over. It's a very important topic.
Good evening, ladies and gentlemen, chairman, co-chairman. My job is to keep you awake for just a few more minutes. Greetings from Indian Orthopedic Society, UK. I come from a place in West Yorkshire called Huddersfield, and my job today is to discuss in next few minutes about whether the controversy is still persisting or is it really over. I'll be talking about what is the controversy and why it is there, and whether it is over or still some issues are still there to talk about this. Let's start with what is or was the controversy. The controversy is there because the proponents of both sliding hip screw or a nail say their implant is the best. Sliding hip screw, people say it's less cost, it's gold standard, it's easy to do, it's less pre and peroperative complication. If you talk to the nail guys, they say we do it with minimal incision, less blood loss, less tissue damage. It's biomechanically a better implant. With the improved design, they claim that complication is less. They claim it's a better outcome both early and late, and early mobilization and shorter hospital stay is better with an implant like an IM nail. Let's first talk about the facts. The facts remains that intramedullary device have got a shorter lever arm, and because of that the bending moment is less. So it is definitely a biomechanically a better implant compared to an extramedullary plate. Also, which has become more important now, is not only it has got a shorter lever arm, it is an intramedullary buttress. So when the collapse happen, although it allow that collapse to happen, but it is gradual, and after some time it can avoid the excessive collapse, which can be an advantage for an intramedullary device. What we also know about intramedullary device is technically demanding. It has got a long learning curve. It's a less forgiving implant compared to a DHS. It is no doubt costly, which probably depends on where you come from, but still overall it's a costly implant. Per and post-operative complication, especially the fracture, peri-implant fracture, is now become controversial, especially with few design change. The big metastasis from Bhandari et al., that group has said that there is no more increased risk with nail now. So we can say almost the peri-implant complication, especially the fracture, is not a big issue with the intramedullary device anymore. So why is the controversy still? I hope this slide will keep you in a mood for a good Bollywood evening you're having. The controversy is that when we start talking about one implant for every situation without realizing that the extracapsular fracture, or if you want to include subtrochanteric fracture, are very different fracture patterns, and the combination and stability is an issue. And we should be talking, if you want to solve this controversy, we should be talking about that the one implant doesn't suit every category. If you see most of the studies which have been published, they're combining all extracapsular fractures, right from A1 to A3 and some even the subtrochanteric fracture, and then using one implant in one situation and the other implant in the situation of the similar fracture. And that's why the controversy is there, because my impression or my understanding that these fractures are very different. And if you choose these implants which works very differently biomechanically, probably there's no controversy. And I'll explain to you in a few minutes about this. Let's talk about the types of extracapsular fracture we know of. On the top range, we got the A1 variety, where there is a normal obliquity of fracture running from great trochanter to lesser trochanter. There is no combinations. It can be A1, A2, A3, but let's not talk about the subgroups, but a normal obliquity without communication. Then although normal obliquity, but with communication, and then is the reverse obliquity, which you normally see, or maybe a transverse fracture with a breach of the lateral cortex. And let's see which implant will work in which situation. And let's see whether one implant fits all approach is a possible approach, or we should now think of doing a particular implant in a situation, and then we can solve this controversy. So let's start with the very top one, the A1 fractures. These fractures, as I told you, run in a normal obliquity. There's hardly any combination. And for this, a simple DHS will work fine. A simple problem, get a simple implant. It's a cost-effective solution. And if you see, there's a gradual collapse because this is not much combination. There is a simple fracture line. This fracture heals quite well with a dynamic or sliding hip screw. And this has been proven that not only a sliding hip screw is equally good, it probably is better, because in a large study, they have proven that the reoperation rate of a sliding hip screw is almost half compared to IM nail. So why to go for an implant which has got a high reoperation rate? So in my understanding that a classical A1 fracture, a sliding hip screw or a dynamic hip screw is a good implant. IM nail should not be used for that. Let's talk about A3. Let's forget about the middle bit for the time being. In the A3 implant, as I told you, it is the pattern of the fracture and the comminution, two things we have to think about. This pattern, which we talk about, running from lesser trochanter outwards in that reverse obliquity, or even if it is a transverse fracture, but the breach of the lateral cortex. And let's see what happens if you use your sliding hip screw in this. Once you use a sliding hip screw, the main fracture line is here. So this fracture will keep on collapsing. The proximal fragment will keep on lateralizing. the distal fragment will keep medializing. And what will happen to this plant if you fix it with a sliding hip screw? Eventually, the collapse will be such that it will be no more collapsible. The dynamic effect will be lost. It become a static implant, and this fracture will fail. So this will not work in a reverse oblique fractures. And this has been proven time and again. What will a gamma nail do in this case, or an intramedullary device? As I told you, not only it's a biomechanically better implant because of the smaller lever arm, but because it acts like an intramedullary buttress, it will prevent that gradual collapse. It will allow to fracture the heel, but it will carry on preventing that significant collapse which you don't want in a comminuted fracture. And this is how the two implants differ in a reverse obliquity fracture. This becomes a static implant after significant collapse. The intramedullary device stops the significant collapse, although it's allow the dynamization, and this fracture will carry on healing. And this has been proven in literature. This article yet to be published, it's in the press, and it has proven that, in fact, in these patients, it's the reverse. The sliding hip screw has got a more chances of failure, more chances of reoperation compared to your IM nail. So let's see what we have solved the controversy so far. So far, for a A1, a sliding hip screw is a good implant. For A3, which is a reverse obliquity or any transverse fracture breaching the lateral cortex, IM nail is a better implant. What about the A2? A2 is slightly a tricky area because the fracture pattern is here, although is a normal obliquity, but comminution keep on increasing as the severity of the fracture keep on increasing. So let's see a bit more detail in these fractures. What happen if you use gamma nail and what will happen if you use intramedullary device. What has come to notice recently, this is a 2013 paper, is the thickness of this lateral cortex, which is very important when you're treating these fractures. The lateral cortex buttress, and it all depends on whether you understand whether this is going to remain after your operation, this lateral buttress or not, and then you will understand which implant will work here or not. So if the buttress is quite thick, this D length, then even if you do a DHS, it will gradually compress and it will work. But if this is very thin, and especially in comminution fracture, what happens is this is get knocked off while you're doing your DHS implant. And this fracture, which is a A2 fracture, actually get converted into A3 fractures. And most of these fractures, once you start reaming there, this cortex is breached, the lateral cortex, which is a definition of an A3 fracture. So this fracture from a normal obliquity, the main fracture line, actually become a more complex fracture than the original fracture and the iatrogenic fracture here. And in this situation, it become from a simple A2 fracture to A3 fracture. And here are a few examples. You put a dynamic hip screw or sliding hip screw. You have not realized this is a thin cortex here. You have broken that cortex, and this fracture, now this become an obliquity going here. This will keep collapsing because nothing to stop it, and this will eventually fail because this will keep collapsing, and the implant will become from a dynamic implant to a static implant in a reverse obliquity fracture, and this will fail. And this has been proven. This is another 2013 study, which has a Norwegian study, which has confirmed that in an A1 fracture, if you do a sliding hip screw, the lateral wall remain intact almost in 95% of the cases. But if you do it in an A2 fracture, there's almost 40% chance of converting them into an A3 group. So you can easily breach that cortex. To solve this problem, some people have started using a trochanteric stabilizing plate to your normal sliding hip screw. The long result of this are not known yet. Some people claim that that has solved if you are very enthusiastic of the plating of all the fractures. But in my opinion, A1 fracture and less comminuted fracture like A2, A1, where you still got significant lateral width, it's stable fracture, a dynamic hip screw or sliding hip screw will work, whereas A2 and A3, where you can iatrogenic create them to an A3 fracture, or all three A3 fracture or subtrochanteric fracture, the implant of choice is intramedullary device. So A1, A2, 1, stable trochanteric fracture, sliding hip screw, and A2, 2, 3, and all A3 fracture, intramedullary hip device. I think that's the end of the controversy. Thank you very much.
Thank you, Ravin. That was a very nice and lucid talk about a very difficult topic. And Any questions from the audience?
Sorry, thank you. That was indeed a very nice talk. I'm just curious about any correlations with bone density and the two different implants.
Yes, well, the group we're dealing with, we universally agree they are all bone deficient, they are osteoporotic fracture.
No, what I meant was, would you use the same algorithm in somebody who's 40?
I would, for a subtrochanteric, for all A3 fracture, I will use a intramedullary device. Obviously, when you're talking about the subgroup I shown A2, where you can have different combination, if the bone quality is good and the lateral width is good, all we have to always think is, can I create this fracture into a more unstable pattern by putting my reamer in? And that's what we have to think. Obviously, a 80-year-old granny with osteoporotic fracture, that's very likely to happen even with a thick width. Sure. Whereas a road traffic accident in a, say, 30-year motorbiker, even if it's got a little lateral cortex, you can assume that you will not break it. But so I think every case is different, as long as the fundamental understanding that there is a high chance of iatrogenic hierarchy of these fractures. You can go a ladder up with your own iatrogenic procedure.
But you don't belong to the family that says use a nail for all younger fractures.
And I come to a place where actually the gamma nail was invented, and we use all the nail, but we have proven that nail has got their own complication. Nail works well in certain situation if you understand how it works. It does have its own lots of periprosthetic fracture, and it is technically, I think, compared to DHS, there will be more complication with nail.
So you recommend that suppose you're doing the surgery and then you convert this A2 to A3, then abandon the procedure and go to nailing?
Yes, most likely that patient will fail rather than bringing that patient for a second surgery, and most of the time these patients require one surgery. So if you realize that you have converted this fracture into an A3, there's no point continuing with an implant which is likely to fail. And there's no point in bringing these 80 and 90-year-old grannies back to theater after 6 weeks, 7 weeks, 8 weeks. Just convert it to a gamma nail there and then, and you'll be fine.
Don't forget the grandpas as well.
Alcohol keep them happy.
Thank you, Ravinder. Thank you so much. That's the end of the session.
Thank you.
Yeah, I know. This is